It's nice to have everybody here. What we're going to be doing is going over a basic lecture, an introduction lecture to a pretty broad topic. So let's just see, make sure we're all set up here. First, I want to thank implantcompare.com. Awesome group, awesome concept. The people at Implant Compare are just incredible. So I just wanted to say thank you to them for having me on board. Looking forward to contributing here. So before we get started, here's my presentation. The first slide, obviously you can see I have my Facebook, Instagram, Twitter, LinkedIn, mail. If you want to get a hold of me, I'm pretty easygoing and I'll answer pretty much any questions anybody has. So if you have any questions, that's my Instagram is probably what I'm most active on. It's at Dr Sinada. Or if you want to email me, my email is naif.sinada@gmail.com, and I'll add that again towards the end. But just an introduction to who I am. I graduated from the University of Iowa, and I did Master's of Public Health there. After graduation, I did biology for undergrad, who didn't? And then I did dental school at the best dental school in the world. That's Midwestern University in Arizona. Then I did a GPR in New York, in Brooklyn, at Brookdale Hospital. Few of the subscribers here from there, so hello, shout out to the Brookdale people. And then after that, I did my pros training. I'm doing 3 years of a pros training at the University of Maryland. That's probably where most of this content comes from. It's pretty intense what pros residents do in terms of a schedule, in terms of the scope of the stuff that we do. So I thought it'd be nice to get a different perspective, and the people at Implant Compare kind of agree to have a different perspective. We're sort of flooded with implant surgery. All we get is surgery, and it's nice to kind of get the prosthetics aspect of it and to see where those beautiful implant placements that people are posting online, where they end up leading to. Because ultimately, if we have these wonderful placements but the prosthetics are garbage, it's probably not going to last. So it's nice to have a sort of a prosthetic background to all this. So again, here's my information. It's at Dr Sinada. Feel free to get a hold of me. Honestly, message me. I get messages all the time, and you know, whoever's messaged me here that's listening has gotten responses, and I'm pretty quick with responses. If I don't, I'll let you know that I'll be a little bit. But anyway, so the topic today is prosthesis-driven implant surgery. What does that mean? Essentially, we're going to be going through and talking about a whole bunch of different topics. It should be short, probably 30 minutes or so, but this topic we can probably go around talking about it for a whole day. But the essential thing, if you don't get anything out of this lecture, what I want you to think about is if you fail to plan, you plan to fail. And that's sort of what all prosthodontists always think. And that's kind of the mindset that we get into. In pros training, we typically don't teach you anything new. You don't learn how to cut a crown prep new. You don't learn a hidden secret on how to place an implant or how to restore an implant. They kind of teach you to think differently. So it's sort of a mindset that you get into. It's almost like law school. They're not teaching you anything new. They're just teaching you to think like a lawyer, or in our sense, think like a prosthodontist. That's the perspective that we get in terms of thinking of these complex treatments. So in general, what we'll be talking about today is getting into that mindset of planning, and if you fail to plan, you're planning to fail. And in doing so, we're going to be talking about prosthesis-driven implant surgery. So we'll talk about what that means, different approaches on how to do that, and then also just show you some clinical applications on what we're talking about and how that applies clinically. The main thing that I want everyone to take out of this is predictable outcomes. Okay, what does that mean to have predictable outcomes? The last thing you want to be doing is having a patient going through expensive treatment, extensive treatment, and then have the outcome be not what you expect, and more unfortunately have the outcome be not what the patient expects. So thinking in this way and thinking in this mindset of prosthesis-driven implant surgery, we want predictable outcomes so that you can predict the outcome before you even begin any surgery and before you even begin and sort of in the treatment planning phases. So what do I mean by prosthesis-driven implant surgery? One of the things we always talk about is patient doesn't come wanting implants. I know that sounds silly to most people, but nobody comes in your office, well, some people will, but mostly people don't come into your office saying, I want implants. They want teeth. They want replacements for what they have in their mouth. So this is a patient coming in with a tooth. Basically what we used to do is take the tooth out, put the implant in, and then plan for the crown to go over it. So in this case, a traditional approach would be you're missing a tooth, and let's just talk about a single tooth approach. We're not talking about full dentures or over dentures. Let's just talk about a single tooth. The traditional approach is to have a missing tooth, and then you put the implant in, or your surgeon puts the implant in. This looks wonderful, doesn't it? You have a beautiful amount of bone around it. This theoretically could be a beautiful implant placement. You have a nice, let's just assume 2 millimeters of bone on the buccal, 2 millimeters bone on the lingual. This could be a beautiful implant placement, but is it? And that's kind of why I put a question mark towards the end there. Is this a beautiful implant placement? To me, from my perspective, the only way I can tell if it's a beautiful implant placement is if I know where the crown is going to be. So let's look at the implant angulation. Again, this looks like biologically a beautiful implant. But if you consider where the crown is going to be, and assuming hypothetically this is where the crown is going to be, I would argue that this is not a great implant placement. I can still restore it. I can put a custom abutment on it. We can find different ways to restore it. But in terms of ideal, I would say this is not an ideal implant placement. Just looking at the angulation, you can see that the angulation is coming straight out of the buccal. So if you did want a screw retained option, this would probably not be an implant where you would do that. So I would argue this is not an ideal placement. So what would I want to do in terms of this prosthesis-driven approach? And this is an approach, this is not an approach that I've come up with. This is not a concept that I've come up with. This is sort of a thinking that's been driving prosthetics and been driving prosthodontists over the past 10, 20, and even longer, 10, 20 years. And essentially the problem that most people have been having is what we just described. You get an implant back, it looks beautiful. You have nice bone around it. Surgically, it's beautifully done. The healing is great. And then you go to try to put a crown over it. You get an impression, and you look at it, and you're like, oh man, this is not where we needed it to go. So the patient's end, they think they have a wonderful implant. And then when we come in, we're telling them, I'm sorry, this crown is going to have to be an extra cost because of this extra implant abutment, etc. So this is sort of how we've been thinking. It's thinking from the teeth first, or thinking with the end in mind. And that's why we say this is prosthesis driven. So first you determine where the tooth position should go. So before you even put the implant in, you figure out where the tooth should go. You can do this with a wax up, you can do it with an Essex, and even cheaply just do it by grabbing a denture tooth. Then you place your implant based on where that crown should go. So you can see that the angulation on this implant is much more different than the angulation on the implant before. And looking at it through this lens, you can tell that with this implant angulation, now I would say that this is an ideal placement. This is all hypothetical. This isn't an actual, this obviously is not an actual case, but we'll go over some cases on how this can be applied and how we've applied this in the past and how I like to practice nowadays. So when you're making a presentation for something like this, it's sort of difficult to figure out what your target audience is. So if anybody is having trouble following, or if anybody wants it to be more detailed, or if you have any questions at all, go to Slido, SLI.do, and I'll be checking it here throughout. I've been getting some questions meanwhile. If you go to Slido, SLI.do, the event code is 3060. So yeah, if this is too basic or if this is too complicated, you just let me know and shoot me some questions, and we'll kind of go from there. Okay? So this is sort of how we're looking at it. The traditional approach on the left, how I originally explained it, it's still restorable and it's still doable, but it's not a predictable outcome. By looking at it in a prosthesis-driven approach, on the right we see we have a crown first, then the implant's placed, and now we can get a screw retained option. Cement retained options are completely fine too, but for me, I typically prefer to have screw retained options. It's one less thing for me to worry about getting cement down into the implant. So again, we'll be talking about the more details of each parts of these in the next upcoming series. So the next one we're doing will be in front of a live audience. So just keep that in mind. If you have any questions, again, just shoot them over into Slido or let me know here and we'll talk about them. So why do we do it this way? Why do I harp about this prosthesis-driven approach? And this is sort of a typical day in what I see in terms of patients, and I get something back like this. Wonderful patient, she's gone through a bunch of treatment to get to this stage. She's gone through grafting, she's gone through implant placement, and now I'm having to make a temporary crown, and you can see in this patient, the temporary crown screw access is out of the facial. Again, I can probably restore this anyway, but just letting you know that if we do it without planning where the tooth should go, you can tell that we could be in for some trouble. Actually, I like to refer to these as headlight implants because if you put a light on it, you could probably light up the entire room. So this is not what we want to avoid. This is what we want to avoid. So this is the same patient. I have, fortunately for this patient, we were planning on doing a full arch of crowns. She had a bunch of old failing crowns that we're replacing. So you can see the crown preps here from, I think on this image you can just see up to 5, but we've got it up to, it's from 3 to 14. And then on number 9, you can see that I had to basically make a zirconia custom abutment. The access again is completely facial, so you can see where the facial is on that abutment, and that's just not an ideal abutment because I'm having to make the crown prep go where the tooth is and the implant is just not there. But fortunately for this patient, I was able to do this, and these are the final crowns. Okay, so they're Emax crowns. It's milled Emax, and then it's cut back and stacked on the facial. But the important thing is that this patient was able to walk out at the end of the day with a cement retained crown. But in between, there was a lot of guesswork as to whether will we be able to restore this. And lots of times, I'm okay with telling a patient that the crown or the implant has to be removed and redone. But in this case, it was not. And I think we're at a decent outcome. If you look at the gingival zeniths between numbers 8 and number 9, they're a little bit off by maybe a millimeter or half a millimeter, but overall I'd say this patient was pretty happy, and we're pretty happy at the end. But how do we avoid doing all this and having to worry about all that in the first place? Is by starting with the end in mind, and that's what we talked about in the beginning, of starting with the crowns first, then placing your implants based on where those crowns should go. And that's essentially what's called front-end treatment planning, as we treatment plan for the end in the beginning. And more or less is sort of the thematic as we think of where are we now and what do we have. And we would have an edentulous site. This can be applied for more than just single teeth. It can be applied to overdentures. It can be applied to full arch treatment. And that's what we'll be going over in the future lecture series. So we think of where are we now, then we think of where do we want to be, or where should the crown go, and then how do we get there. So there's different approaches for prosthesis-driven treatment planning. The traditional approach is freehanded. I would argue, and if you listen to a few other contributors here on Implant Compare, Dr. Kepke, for example, we'll talk about freehanded just being a thing of the past, and I would agree with that. It's doable, and sometimes we can get lucky and get implants really where we want them. But for the most part, I typically try not to do things free-handed if I can avoid it. There are situations that you can't avoid it, emergency situations, etc. But for the most part, I would like to move towards guided or guide-assisted surgery. And guide-assisted surgery is something where the implant is not fully guided, but you at least have a guide to assist you on where you need to go. And then that's why I have it in green, is fully guided surgery. Anytime I can, I will go fully guided surgery. Or if I'm referring it to a surgeon, I'll have the surgeon go fully guided. With fully guided surgery, there are no excuses as to why the implant shouldn't be where they are because you've treatment planned it from the beginning. And this way, you, the patient, the surgeon, everyone's on board before you've even started. So what do I mean by freehand? Here's an example of a case that I did first starting. You can see that this is a free-handed surgery. There's no sort of guide holding me on where I should go, but just look at that implant angulation based on where my burr is going. That's headed into where the socket is headed. The socket is much more facial than where the incisal edge should be. So if I would have continued this free-handed surgery, just going where I would have, we would have had a screw access or an implant angulation that would have been coming out the facial. Fortunately, this is corrected, and this is an immediate implant, so this is corrected for during surgery, and I'll show you here in the next slide what our final result was, but this is kind of what we ended up with. I would say in this one, we got lucky. Okay, you can see where the incisal edge is, and you can see where the screw access is completely lingual to that incisal edge, but I'd say we got lucky with that. Nowadays, how I practice now, I don't want to have to get lucky. I want to be able to know exactly where my screw is going to come out before we do that. So just a few questions here. Jesse's asking, as a restorative doctor, how do you work with the surgeon to better prepare? And that's a great question. I'm actually not going to respond to these on the website. I'll just talk through it. But as a restorative doctor, how do you work with the surgeon to better prepare? That's exactly what we're getting to. The first thing we want to do is plan with the end in mind. If before you've even started the implant, you, the patient, and the surgeon all know where that crown has to go, then you're better prepared just from the get-go. Okay, so even if this was freehand, if we knew where this crown was going to go, we're already better prepared. Now we're starting to move towards guide-assisted surgery. And this guide-assisted surgery, for example, is a crown where I don't have, I'm missing a tooth. Okay, so what I would do first is just wax up this tooth and put the tooth where it needs to go. And in this case, we see that number 13 is exactly where it needs to go. And then I make a guide that fits over there, okay? And I can go over the details of this if anybody wants me to, but more or less I make a guide, and you can see there's a hole coming right out of the middle of where number 13 should be, okay? So that when I come in to do surgery, I'm not going to use this for a final implant placement, but once everything is flapped, I put this guide on and use it to make a hole or just some sort of dot. And now that dot essentially tells me where I should start my osteotomy and where it should finish. So if you look at the surgery, this is during that surgery. We use that guide to find out where we should go, and Dr. Jack Chow made this surgery. Jack G, I'm sorry, did this surgery. And this is the final crown that I was able to put into it. It's a screw retained crown. Again, I'm okay with custom abutments or cement retained crowns, I'm sorry. But if I can get it screw retained, that's just one less thing for me to worry about. And in this case, this is a year follow-up of this implant. Beautiful implant, crestal bone levels. So I would say that, going back to Jesse's question, by knowing where the crown should go first and having the periodontist, the oral surgeon, or whoever's doing the surgery, or if you're doing the surgery yourself, having them on board before you start helps you just be better prepared. And this is where we're going to answer your question here, Jesse, and is with guided surgery. This is where I think the future is headed, or what I would argue with how I'm practicing nowadays. This is where we are, and this is what I think should be probably the standard. Here's a case of guided surgery. You can use guided surgery for anything you can think of in terms of implant placement. It can be for a single tooth. It can be for multiple teeth. It can be for overdentures, for a edentulous, for all on 4, 6, 8, whatever you're thinking. You can essentially use a computer and use CT planning to get you where you need to go. So in this case, we're working on number 9. Single tooth might seem like overkill, but the two teeth, number 8 and 10, were angulated towards each other, so it gives us a lot less space for us to worry about. And I can usually make these guides in-house. We can print them 3D printing anyway, so It really, for us personally, there's no excuse for why we should not do it this way. So somebody's asking, what surgical planning software do you recommend for making your guides? Man, that could probably be a day lecture on its own. I've used a lot of different softwares. I've used Nobel guided software. I've used Anatomage. These are all, if I'm mentioning them, then they're worth using. I've used ones that I'm not going to mention, but Nobel, Anatomage, 3Shape has a great implant studio, but lately I've been using a lot of Blue Sky Bio for my implant planning. And then Mesh Mixer is a free 3D printing software and 3D manipulation software that I use also. So it really kind of depends on what you have in your office in terms of tools and toys. So feel free to shoot me an email or let me know on online, and I'll kind of walk you through what based on what you've got. So here's guided surgery for number 9. So we have missing number 9. But what do we do first, and what have we been talking about? What we do first is figure out where the tooth should go. So number 9's missing. In this case, it was extracted, but there's a cast from before the extraction, and all we do is just wax it up to determine where the tooth should go. It doesn't have to be a great wax up. As you can tell, I'm kind of sloppy here. I don't have much of my contours, but I have my incisal edge in the right position, my facial contours exactly where I want them to go, and more or less the tooth exactly where I want to go. I don't need to wax up the lingual contours and make the cingulum perfect, but I do need it to go exactly where it needs to. So once I determine where that tooth is, I scan that digitally. So this is a scan with my implant planning software, and this one actually in particular is with the Nobel clinician. I don't have any particular ties to anything. This just happened to be with the Nobel software, but I'll probably show you later on, and then in the next series I'll be talking about one I've done with the Blue Sky Bio software and where I made my own guide with Mesh Mixer. So in this case, it's a digital prosthesis driven implant planning. So you can see in red on the top there's an outline of the crown from the facial, and then on the right, top right, there's an outline of the crown from the incisal, and that green circle is exactly where I want my implant to go. Okay, so here, there's my screw access. If I get this implant exactly where it needs to go and where I've planned for it, and there's no reason it shouldn't, then I should be able to get my screw access. And I make my guide based on that implant. Nice thing about these guides is that you can have it exactly, depth, angulation, everything is controlled except for the timing. So the implant is placed fully guided into the mouth, and you can see here there's little windows I put in so that you can see and make sure that the guide is fully seated. When it's tooth-borne like this, there's no reason it shouldn't be fully seated, but more or less the guide is placed exactly where it needs to go, depth-wise, height-wise, and all that. So we got screw access on the temporary crown, which is great. The patient can walk out of the office with a crown, and they don't have to walk around with an Essex retainer or a removable partial, which can still be great treatment options, but just not how I personally want to practice. If I can get the patient into something fixed right away, I would love to do that. So immediately, this is how the implant was, immediate post-op, and I was able to put a crown on it right away. So this is a 2-week follow-up. Just took an x-ray to see where the implant looks like, just kind of as a baseline, and you can see I have some gaps between the implant and the bone. And then when he comes back in 6 months, and this normally I'll restore these in about 3 months, but in 6 months the patient came back, all those gaps that you were seeing before is completely closed. This implant was fully osseointegrated, so they're sent back to the restorative doctor to make the final crown. But you can see that this is a prosthesis driven approach. Okay, everyone is on board, the surgeon's on board, the prosthetics are on board, and the patient is on board, so everyone kind of can have a predictable outcome before we even begin. So you can use it for more than just guided single tooth. You can have guided overdentures, guided full arch implant prosthesis, and again, the most important thing that we want to get out of all this is that we want to have predictable outcomes. So this is what I'll be talking about in our next treatment seminar, is guided overdentures. Lots of people, when I first started doing these, lots of people gave me a hard time about doing these. Why do you need guided overdentures? Why don't you just flap it open, put 2 implants where they need to go, and just get a denture over it? Lots of times that could be the case. But if I don't know where that denture needs to go, I can show you probably a whole album of where implants ended up where they shouldn't have been, and now the contours of the dentures are compromised. Now patients have an outcome that they weren't predicting for in the beginning, and then somebody has to have an uncomfortable conversation. Thank you, Dr. Anderson. So for this patient in particular, this is what I'll be talking about next time, you can see this here is the floor of the mouth, and that's pretty low. Oh, sorry, this is the ridge. This is the floor of the mouth, okay? The floor of the mouth is higher than where the crest of the ridge is, and this is the attachment to the genial tubercles. So you can see how much this patient has lost bone in. I would not treat this patient with typical implant therapy for overdentures unless I did this guided. The amount of bone left is just not very much. We don't have very much room for error, but most importantly, we don't know where the crowns or where the dentures should go. So we'll go over kind of how to get this patient from this stage of having removable dentures that just don't work to having an outcome that is exactly where you want it to go. We did guided implants on the maxilla, and he has an overdenture on the maxilla, but more importantly, you can see that these implants ended up exactly where they needed to go in terms of the attached tissue. There's not much attached tissue left, but at least we're maximizing the chances of these implants succeeding. So what do we want to get out of this? The most important thing, like I said, is to just think about things differently. We're not going to be doing things any differently. It's still the same implant placement. But at the end of the day, we're thinking of the prosthetics first, and that's what's driving our treatment planning. And then if I can, when I can, which in my practice, how I practice mostly is guided surgery is preferred. If I can, I'll do it guided. If not, we'll at least do it guide assisted. And then unless there's reason to, I'll go completely freehand with no reference of where the crown is. But I typically won't even take those cases on. And how you've heard a lot of people here lecture, and how you hear a lot of other people, I think, in the future is guided surgery the future, or would you say at this point it's the standard? And I would argue that it's at least the standard of care to think of things in the prosthetics first. And whether you would argue that guided surgery is preferred, I think if it was my sister, or if it was my cousin or brother getting treatment, I would say that definitely thinking of things prosthesis driven is a must, but I would for sure, for an immediate family member, have guided surgery done if I could have that choice. So here's my information for anybody that wants to get a hold of me. So it's a quick half-hour lecture just to get people kind of on board with what I'm thinking about and what the mindset that we kind of will be taking these next lecture series on. It's at Dr Sinada, and below is my email. If you want to get a hold of me, go ahead and email me. That's not a big deal at all. And then Instagram. Sorry, I'm just going to answer some questions here. On Instagram, Dr Sinada is probably what you'll get a hold of me the fastest on. I do have Facebook, Twitter, and LinkedIn, but I'd probably get fastest response with Instagram. So another question over what software I like to use. Like I said, I've used a lot of different softwares. It's what you're most comfortable with, and it's what you have at hand. If you're just getting started, and let's say after you're done with this lecture, you're thinking, all right, I think I like this idea. Let's at least get started and get on board with some planning software. I would say go ahead and right now go on and download Blue Sky Plan or Blue Sky Bio. It's free. You can go on there, download an implant. If you have a CT scan for any of your patients, you can go ahead and upload it onto that software and immediately be able to plan for where your implants should go. Even if you're not the surgeon on the case, I think just planning for where the implants should go, you can easily tell, one, how difficult things are, and two, you can also tell how important of a role it is that you place as a referring doctor. I think the days of sending over a slip saying that the patient needs number 9 or sending a slip over that says patient needs number 5. I think those days are over. With technology how we have it now, there should be no reason that there shouldn't be digital communication between surgeons and the referring doctor for where implants should go. Cristo wants to know when I'm having the overdenture lecture. I believe it'll be in 2 weeks. I'll keep you guys posted on at Dr Sinada. I'll post hopefully a couple days before, let you know where the lecture is. But the lecture will be in Maryland. There'll be a live audience too, but I believe it's in a week. I'll double check and let you guys know on Instagram. All right, again, if you have any questions, I've really enjoyed having you guys over and talking to you. If you have any questions, here's my information. Email is completely fine. At Dr Sinada is completely fine too. So I'm looking forward to talking to you guys soon. And thanks for paying attention.
Implant Compare is a service that allows its users to connect with dental practitioners from around the world. Implant Compare conveniently offers an app and website for users to log in to watch live dental surgeries, view archived surgeries, or watch from a series of lectures from Implant Compare's contributors. This interactive way of streaming surgeries allows the user to feel like they are in the operating room by granting the user permission to ask questions in real time. Whether the user is a dental professional looking to expand his or her knowledge and best practices, or someone who is seeking to learn more information about maxillofacial surgery, Implant Compare is a convenient, easy, and free way to view oral surgery techniques from across the world.